Welcome everyone to this Step 2 tutorial on pleural diseases and lung cancer. Today we'll cover high-yield question strategies that will help you succeed on your board exams. This tutorial focuses on the clinical scenarios you're most likely to encounter and provides a systematic approach to answering these questions correctly. Let's dive in and build your confidence for test day. These are our 4 key learning objectives for today. First, we'll master the light criteria, which is absolutely essential for distinguishing transudative from exudative pleural effusions. Second, we'll develop a systematic approach to pneumothorax questions based on patient stability. Third, we'll review lung cancer screening criteria, which frequently appear on boards. And fourth, we'll learn how to navigate solitary pulmonary nodule evaluation using Fleischner Society guidelines. Keep these objectives in mind as we work through each case. Here's your test-taking framework for pleural and lung questions. Step 1 is always to identify the clinical scenario. For pleural effusions, look for blunting of the costophrenic angle, the meniscus sign, or layering on decubitus films. For pneumothorax, look for absent lung markings, a visceral pleural line, or the deep sulcus sign on supine films. For lung masses, focus on size, calcification pattern, and patient risk factors. Step 2 is applying the appropriate decision algorithm. Effusions need thoracentesis, followed by light criteria. Pneumothorax management depends on stability. Nodule workup depends on size plus risk factors. Masses require staging with tissue diagnosis. Let's review the high-yield buzzword associations that board examiners love to test. For pleural effusion, the classic triad is dullness to percussion, decreased breath sounds, and decreased tactile fremitus. For pneumothorax, think hyperresonance, absent breath sounds, and the classic patient is a tall, thin, young male. For lung cancer, the key associations are smoking history, weight loss, hemoptysis, and a spiculated mass on imaging. When you see these buzzwords in a question stem, immediately think of these diagnoses. Now let's apply what we've learned to our first case. This is a classic presentation of a new pleural effusion. We have a 62-year-old man with congestive heart failure and progressive dyspnea. The chest X-ray shows bilateral effusions. The question provides all the thoracentesis values we need to apply the light criteria. Before revealing the answer, take a moment to calculate the ratios yourself and determine whether this is transudative or exudative. Let's walk through this case step by step. Step 1. Know the light criteria cold. An effusion is exudative if any one of 3 criteria is met. Protein ratio greater than 0.5, LDH ratio greater than 0.6, or pleural LDH greater than 2/3 the upper limit of normal. Step 2. Calculate each ratio. The protein ratio is 3.2 divided by 6.5, which equals 0.49, just under the 0.5 cutoff. The LDH ratio is 90 divided by 220, which equals 0.41, well under 0.6. The absolute LDH of 90 is also well below the threshold. Step 3. Apply the rule. Since none of the criteria are met, this is a transudative effusion. The test-taking tip here is that heart failure is the classic cause of transudative effusion. When all light criteria are negative, think transudate. Here's our second case focusing on exudative effusion workup. This 55-year-old woman has had recent pneumonia and now has persistent dyspnea. Her thoracentesis shows values that clearly indicate an exudate, but notice the additional findings: cloudy fluid, low glucose of 40, and a pH of 7.1. These are critical clues. Read through the answer choices and think about what these additional findings tell us about the next best step in management. Let's work through this case systematically. Step 1. Confirm this is an exudate. The LDH ratio of 300 divided by 180 equals 1.67, which is clearly greater than 0.6, confirming exudate. The history of pneumonia points to parapneumonic origin. Step 2. Look for complicated features. This is the critical step. A complicated parapneumonic effusion has specific indicators: pH less than 7.2, glucose less than 60, LDH greater than 1000, or positive gram stain or culture. This patient has a pH of 7.1 and glucose of 40, both meeting criteria for a complicated effusion. The test tip to remember is low pH plus low glucose equals complicated effusion needing drainage. Now let's go through why each answer choice is right or wrong. Answer A, observation, is wrong because complicated effusions do not resolve spontaneously. Delay leads to empyema and loculations requiring surgery. Answer B, chest tube placement, is correct. Drainage is required for complicated parapneumonic effusions. This is the standard of care. Answer C, diuresis, is wrong because diuretics treat transudates, not infected exudates. Answer D, surgery, is wrong as a first step. VATS with decortication is reserved for failed chest tube drainage or empyema with loculations. Always try drainage first. Case 3 presents a classic pneumothorax scenario. We have a 24-year-old tall, thin man, the classic patient demographic, with sudden onset chest pain while lifting weights. He's also a smoker, which increases risk. His vitals show mild tachycardia and borderline hypoxia. The exam shows decreased breath sounds and hyperresonance on the right, our classic pneumothorax findings. The trachea is midline, which is important. The chest X-ray confirms a 25% right pneumothorax. Think about what factors determine the management approach. Here's how to work through pneumothorax management questions. Step 1. Always rule out tension pneumothorax first. The signs of tension are hypotension, JVD, and tracheal deviation away from the affected side. This patient has none of these. His trachea is midline and blood pressure is normal. This is a simple pneumothorax, not tension. Step 2. Assess and manage based on size and symptoms. This patient has a 25% pneumothorax, which is considered large. He's also symptomatic with dyspnea and hypoxia. The key test tip is symptomatic OR, large pneumothorax needs intervention. Small plus asymptomatic can be observed. Large OR symptomatic requires chest tube or aspiration. The correct answer is chest tube placement. Case 4 tests lung cancer screening criteria. We have a 58-year-old man presenting for a routine checkup. He has a significant smoking history of 35 pack years but quit 2 years ago. He's completely asymptomatic. This is exactly the type of patient question that appears on boards. Before looking at the answers, try to recall the specific criteria for lung cancer screening with low-dose CT. Let's work through the lung cancer screening criteria systematically. Step 1. Know the criteria. Annual low-dose chest CT is indicated for age 50, 80 years, 20 or more pack year history, and current smoker or quit within the past 15 years. Step 2. Check each criterion for this patient. Age 58 meets the 50-80 criterion. 35 pack years exceeds the 20 pack year threshold. Quit 2 years ago is well within the 15-year window. All criteria are met. Step 3. Eliminate wrong answers. A is wrong because quitting doesn't disqualify you if within 15 years. B is wrong because chest X-ray misses early cancers and isn't recommended for screening. D is wrong because sputum cytology has poor sensitivity. E is wrong because PET is for staging, not screening. The correct answer is C, annual low-dose CT. Case 5 covers solitary pulmonary nodule evaluation. We have a 45-year-old never-smoker woman with an incidental 8mm solid nodule found on CT. She has no history of malignancy, and the nodule has smooth borders without calcification. This tests your knowledge of the Fleischner Society guidelines for pulmonary nodule management. Consider both the patient's risk factors and the nodule characteristics when determining the next step. Here's how to approach pulmonary nodule evaluation. Step 1. Assess risk factors. Low-risk features include never smoker, young age, and no cancer history. High-risk features include smoking history, older age, prior malignancy, spiculated borders, and upper lobe location. This patient is low risk. Step 2. Apply size-based guidelines. For low-risk patients, nodules less than 6 mm need no follow-up. 6 to 8 mm nodules warrant CT at 6 to 12 months. Greater than 8 mm requires more aggressive workup with CT at 3 months, PET, or biopsy. The key test tip is that 8 mm is the threshold for more aggressive workup. This patient has an 8 mm nodule in a low-risk patient, so the correct answer is B, repeat CT in 3 to 6 months. Let's wrap up with key takeaways and final test-taking tips. For board preparation, review the pulmonary chapter in First Aid for Step 2, focusing on pleural diseases and lung cancer. In UWorld, filter by pulmonary system and focus on pleural effusion and lung mass question blocks. Remember these test-taking pearls. For light criteria, if any one criterion is positive, it's exudative. For pneumothorax, tension is a clinical diagnosis requiring immediate needle decompression. Don't wait for imaging. For screening, memorize the age, pack year, and quit window criteria exactly. For nodules, size plus risk determines follow-up intensity. Thank you for watching. Please like and subscribe for more high-yield content and visit roadmap2residency.com for expert tutors and residency advisors.